Hello again. Welcome back. I hope everyone's feeling to get involved in more content from our upcoming speakers. On our next panel, we'll be discussing the role of advice, guidance, and triage in recovery, this time in partnership with Consultant Connect. In 2021-2022, there were 1.3 million fewer unnecessary outpatient attendances due to advice and guidance, and outpatient-based care accounts for 80% of the NHS waiting list. Advice and guidance services can bridge the gap between primary and secondary care, allowing for timely consultations and reducing the need for unnecessary referrals. This not only improves patient outcomes, but also helps in managing resources more effectively. Triage, another critical aspect, involves the systemic sorting and prioritization of patients based on the severity of their conditions. By implementing efficient triage systems, healthcare organizations can ensure patients receive the appropriate level of care on time, helping patient flow, reducing waiting times, and optimizing the allocation of resources. Digital solutions such as telemedicine platforms and AI powered decision support tools can play a huge role in making the services effective. Telemedicine enables remote consultations, allowing healthcare professionals to provide advice and guidance to colleagues and patients from different locations. And AI powered tools can support triage by analysing patient data and symptoms, assisting healthcare providers in prioritising cases and making accurate decisions. So let's welcome to our discussion Lucy Simmons, COO of Consultant. Actually, my thing's gone a bit strange there. Consultant Connect. Anil Vara, Elective Care and Recovery for Hull University Teaching Hospitals NHS, and Sally Shaw, Service Manager and Lead Nurse Community Liaison for Cambridgeshire Community Services. Please do continue to send in your questions, and I'll ask our panelists as many as I can. Well, good morning. Now I can see, good afternoon even. I can see Lucy and Anil. And have we got Sally on there as well? I can't actually see Sally, but I'm hoping she is there. So let's start the conversation off with Anil, if we may. In layman's terms, just explain for anybody in our audience who's not so clear what advice and guidance is and why we need to change the way we manage outpatient appointments to make things more efficient and effective, not only for people giving treatment, but also for patients.
Thank you, Helen, for that introduction and the question. Advice and guidance isn't a new concept. It's been around for some time now. We call it abbreviated to ANG. We like to abbreviate everything in the NHS. So advice and guidance is what we stands for, and written down as ANG. In a simplistic term, advice and guidance is when a GP, rather than making a referral to a provider organization or acute trust for a consultant to see the patient, the GP can actually contact the consultant for advice. So it saves the trip for the patient, it saves time, and the benefit is that the patient can get a much more swifter response to support their care. And the way advice and guidance is done, in the old days, it was done by picking up a telephone to your consultant, you used to know. But now we're moving into the age of digital and using a lot more digital tools to support this. Conventionally, the electronic referral system, or abbreviated as ERS, was the traditional and still is now the main conduit for advice and guidance. So the GP in their practice can actually trigger a referral through advice and guidance. It then the consultant of the provider organization will receive it. They would actually write a response to that in terms of a kind of a care plan, and then the GP will receive that and translate that to the patient. So the key benefits of this is it saves the patient coming into the hospital, which is what is the right thing to do. It supports the carbon footprint. It supports that we use our capacity in the right way in the provider organizations to see the right patients and see the more complex and riskier patients that we have on our waiting list. And it allows that quick response to the patient back via the GP, but also allows any tests that the patient may want to do. So if a patient needs a CT scan, they can actually have it done quickly by getting that advice back to the GP, and then the GP making a referral to the CT scan. So they can all have the test done, get all the preparation for the patients done, and then they can be presented back to the consultant if they need to with all the information so that the patient gets that timely care they need there.
Oh, thank you for a very good description, and it makes a lot of sense. I can see where digital really helps out. Lucy, it's lovely to have you on our panel today from Consultant Connect. You've been there for 4 years. Just for anybody in the audience who's not familiar with what your company does, just give us a little précis of what you do and where you fit into the story here.
Sure. Thanks, Helen, and thanks, everybody. And thanks, Anna, for a great overview of A&G. That was super helpful. So Consultant Connect really provides an enhanced version of advice and guidance alongside a few other services and solutions, which I can come on to later. And I think what we've really tried to do as an organisation is understand where the kind of both operational and clinical pressures are within the NHS and help find solutions. So as Anil mentioned, technology provides lots of opportunity, largely for things like remote consultation. So one of the things we found, especially during COVID and more recently through the industrial action, is the kind of capacity and resource challenge that the NHS is facing. So we have solutions that kind of complement local systems through our external kind of national consultant network, which are consultants across the UK that can kind of supplement and be a kind of additional resource to help provide this advice and guidance. Because as Anil said, I think getting that kind of preventative kind of aspect of work in place is crucial to help reduce some of the kind of unnecessary burden which often takes place if advice and guidance isn't sought at the right time. So what Consultant Connect facilitates is that really rapid advice and guidance, and that's delivered largely through a telephone call. And typically our kind of response rate is 30 seconds. So a GP or a paramedic or a community clinician can speak very quickly to either their local specialty team or out of area consultant and get a really helpful steer on helping them make that decision and what's right for the patient. And, as Anil said, one of the aspects of that is advising on first step diagnostics, so that actually if an outpatient appointment is needed at some stage, then you're kind of going in with that kind of first step done, so it's more informed. So you're potentially kind of saving both the patient, but also the hospital potentially 2 appointments. And then on the kind of other side of providing advice and guidance, we are seeing a growing use of our messaging, which very similar to ERS, again, as Anil mentioned, is the ability to use the same platform, but to share messages with additional attachments. So in the case of dermatology, images of skin, but also in cardiology, the sharing of ECGs. And again, that's done in a really, rapid fashion. So kind of turnaround, often you're talking in hours. So again, kind of GPs feel really well supported in that decision making. And I think finally for us, one of the main things as an organisation, and kind of as you say, I've been here for 4 years, but we've been going longer than that, is I think over the last few years, the plethora of tools and initiatives that have been kind of thrown into play. One of the things we're really good at doing is providing complete end-to-end from advice and guidance right through to that referral and referral triage aspect, which means a GP, for instance, doesn't need to kind of come out of our platform and use ERS. We're completely integrated across that whole journey.
Oh, thank you for explaining that so well. 2 messages to the Jacks in my life. My little Jack, will you put my light on, please, so I can see my little light? And Jack at the conference, I haven't got my little Q&A thing at the bottom in case anybody's putting any questions from the audience. Oh, and I was just going to ask Sally the next question. She's disappeared from my screen, but I'm hoping she still might be able to hear me. Sally, welcome to the panel. Just wondered if you can tell us a bit about your service in Cambridgeshire, presuming that you haven't just dropped off the platform.
Hello, everyone. Can you hear me okay? We're having some IT challenges here. Yeah, it's okay.
We can hear you, Jack.
We can. Lovely. So my name is Sally Shaw. I'm employed by Cambridge Community Services. So I'm actually a district nurse by background. I work with my team at Acute Trust at the Luton Medical Hospital in Luton, and we run on service. It is a nurse since 2007, where our GPs from 4 different ICBs in the area will contact us for patients that require a same-day assessment. Medical or general surgical teams, we just deal with adults predominantly, but we do some children. The GPs all have their own surgery. And we average a response time of about 99.9.3% was in May. All of our calls, which were in May, 794 calls were answered within 25 seconds. That's pretty good. The idea behind us, yes, the idea behind us and us using advice and guidance and Consultant Connect is that actually GPs have a quick access to secondary care. So if they feel their patient they're seeing in the surgery requires assessment on that day, they will pick up the phone, speak to one of my team, and we will advise whether or not there is an alternative community service, whether there's some advice and guidance using an alternative number on the phone, or actually whether they need to come in or not. And we will then actually make a determination with the referrer as to where they are actually have their care provided, whether it be in our emergency surgical unit or anything. So that's us in a nutshell.
That's a very good nutshell. But Sally, are you a fan of A&G, and how do you feel it really benefits, both your medical teams, but also your patients? And I've realized my teenager's got headphones on. So as you start to answer, I'm just going to switch my own light on because he can't hear me. Well, excuse me 1 second. Carry on, Sally.
Yeah, we will pass the GP, bring back and press the appropriate number so that they can contact respiratory. The advice and guidance, and with the speciality of my own team and their knowledge, we actually avoid about 7% of referrals that come through. The aim with the team is to actually stop people unheralded, appearing in A&E unheralded, so that at least we only see people in A&E that are trauma and emergency. The others can actually get need assessment, actually can be seen in the appropriate area. Supports the A&E and the general.
Oh, and so important as well, having been in A&E a few times with parents over the last year, in quite dire scenarios, and realizing how packed it was with people who weren't in dire need, that you realize I know firsthand why those services are so needed. And given that the NHS long-term plan includes ambitions to redesign outpatient services, how successful has it been so far? And what additional work do you think needs doing to make it even smoother and even better?
I think there's been some really good work that has happened. We certainly recognise the pressure on the acute door is getting greater and greater at the moment. So, as part of the elective recovery strategy, the national strategy that was launched, I think it was launched year before last. Now I lose count. But one of the key requirements there was to ensure we've got demand management processes in place to ensure that how can we see the right patient in the right place, ensuring that patients that do need access to acute intervention is seen in a timely way, so that what we can then do is get the treatment phase done as quickly as possible. So I think there has been a lot of work has happened here. I can reflect on some examples through my own system
Yes,
where
please.
we've done a couple of innovations to support better getting advice and guidance. So one of them is Connected for Health. So Connected for Health brings together the GP and the consultant in one place. So what we've done is piloted this initiative, which was back end of a transformational investment fund that we received. And we piloted this initially in cardiology, where we create that one space for the primary care GP and the consultants to come together to discuss a patient's case. Now, that means that the patient could actually have their care managed through that shared care support area, that combined area where the GP and the consultant come together. So that's an active way of giving advice directly and in real time and reducing administration and keeping records very, very simple as well. So the idea is that quick access to that advice by the consultant in that one space happens. If intervention is then needed to the secondary care, the patient is then referred formally to the provider. If the patient benefits from having continued care through the shared care approach, they would continue to use Connected for Health to manage the patient. And if the GP feels that we don't need the consultant support, the GP will manage the patient's care in primary care. So we find that this has been a very, very effective. And the results we've seen is about approximately 40% deflection of unnecessary referrals into the acute space. So that pilot we've now extended into some other areas like diabetes. It's now expanded into areas that we were touching on in more surgical specialities. However, what we would now want to do in the ICB is to do a proposal where we can scale this up so that every patient across Humber and North Yorkshire benefits from this service. And that is the challenge that we're going through at the moment, is how do we scale something like this up when there's potentially resources from both primary and secondary care that need to be joined together to support that. So that's one example, Helen. The other example I can quickly give you is in the North Patch of our county, in the primarily in the York area. We're running something called rapid expert input. And what that means is that we have a referral that's generated by a GP goes to a referral support center. So it's a center that's managed through administrators, and they would do a bit of an admin triage on the referral based on the protocol they've been given. And what they will then do is signpost that referral to the consultant, who would then do a triage on that referral. And as they're doing the triage, they will decide if advice and guidance would be appropriate to be given. And if it is, they would give advice and guidance and send that back. So it's a digital system that allows that option to be given. And if that option is not the right option for the patient, then what they will do is they would signpost the patient back to that RSS team to give them, that team will then give the patient a conversation around patient choice, where they like to go for their treatment, where they like to access the services, where how can they get the easiest access they can, given the geographical social deprivation that we've got in North Yorkshire. It's very varied. So we recognise this, and this is where RSS is very supportive. So the RSS team will support that, and again, if it needs that clinical intervention, the consultant can then automatically change that referral into a clinic appointment to that point. So that's again a very good pilot that we're running, and we're looking to see how we can expand that to see how that works in collaboration with Connected for Health.
Oh, I think examples always bring it to life. And I would imagine, Lucy, that these services probably help NHS areas with their recovery strategies. Do you have examples of that?
Yeah, absolutely, Helen. So referral triage for us has actually been, since the kind of middle of 2020, been a huge growth area. You know, we recognise that there are, I think, 7.2 million waiting on the kind of backlogs, and you know, the time taken to triage and then see patients is really significant in an industry that's already under significant pressure. And as Neil said, I think there's lots of opportunity to treat patients in primary care with the appropriate kind of advice and guidance and a treatment plan. So one of the kind of shifts we've made over the last few years is to utilise that national consultant network. So these are specialist consultants from across the UK to come in and almost provide that kind of virtual, that locum service to help do that triaging. And that we've seen great, success there. So I think we're around the kind of 4,000 referrals triage so far across about 17 different specialties. And what we see is it doesn't come without challenge. It's a new initiative, and one of the things we see is a nervousness around an outsider and a consultant from out of the area coming in and providing that service. But what's lovely is we run really in-depth clinical briefings between our team of consultants and the local team to ensure that we're really clear on local pathways and protocols. So we are just an extension of that team. And generally, when we do those briefings, the consultants know each other or know of each other. So there's a real nice reassurance there and then. And then we kind of follow as if we were the local team, and we do that triaging, as Neil said. And actually, on average, we probably see 25% that can be treated fully in primary care, but actually in some specialties such as ENT, it's often much higher. And on the flip side, what we see is potentially, a nervousness around primary care being swamped again with lots of referrals that they thought were sat in secondary care being returned to them. But the thing we do really thoroughly, and we always kind of audit this process, is to ensure that when we're kind of pushing patients back into primary care, we're doing so with a really clear and robust treatment plan. And when we speak to the primary care teams, they really value the really considered and thorough guidance given. So hopefully that then allows the patient to get the treatment probably quicker and be treated appropriately by their GP. But also, as Anil said, going through this process allows those patients that do need to be seen in secondary care, to be prioritised appropriately. So there might be a more suitable nurse-led clinic, or they might need diagnostics before their outpatient appointment. So it's really about that kind of smart use of resource to ensure the patients get the appropriate care at the right time. And as I say, it's been really successful for us, and I think probably will continue to grow, knowing the kind of continued pressures that the NHS is under.
Oh, I'm sure you will. And Sally, is this something that patients are blissfully unaware of, or do you get feedback from patients? Do they know about these kind of models?
I would actually say from my experience that they probably don't. I think they're probably aware that their GP has referred them. They've spoken to a very nice person, hopefully on the other end of the phone, who would then advise them where they need to go. Certainly from a practical point of view, pre-pandemic, or just as a pandemic and we went into lockdown, we were actually managing to transfer GP liaison service in its entirety out into my home workers. So even our GPs didn't know the technical bits behind it and the fact that we were managing it from home. So I would actually say that it's hopefully a seamless process for the patients, and that's obviously very, very positive for them.
And what about for you, Anna? I mean, do your patients understand any of these terms? Are they familiar with them? Or again, are they just sort of perhaps impressed that the system's working nice and smoothly? And do they not, come across terms like A&G and triage and all that sort of stuff?
It's a good question. I agree with Sally very much. I don't think patients are very aware of these terms and these new models. Certainly, if you look at some of the work we've tried to do to support patients, there's a term called PIFU, who stands for patient-initiated follow-up. So, which means that when patients are put on a follow-up pathway, but the patient is given the empowerment to access the service when they need it. So terms like this would confuse even myself, if I wasn't aware of what it is. And funny enough, when we open these conversations up through our community providers, our GPs, even they're not even aware of what these terms are. Advice and guidance is probably more known because they do it, but these new models of care, such as PIFUing, discharge out, straight to discharge, are new terms which patients are not familiar with. And we did some animations to support patients to get better understanding. So we did develop some animation cartoons and we deployed them out to across our ICB. So these can be shown to a patient. So if a patient is in front of their consultant and the consultant decides to put them on a PIFU pathway, they can show them this animation in a very simplistic form that explains what PIFU is and how to access the service. And that seems to have gone down very well. But
No, I'm sure it has.
I think we still need to do more education around this. And I don't think that we're there yet. We still need to do a lot more education. And certainly the models that I explained earlier, they're definitely not in the remit of patients understanding what shared care is. So how can we help patients to understand that you don't necessarily need to go to a consultant to get the care you need? We can do this through a combined effort, and through the work that we're doing through our clinical networks in my program. we're focusing on more collaboration with primary care to support patients to get the care they need. So again, I think there is an awful lot we still need to do
Yeah, you
around
can see though it's an absolute win-win for everybody
mm,
involved. Lucy, I'm going to pat you on your back now because your referral triage and validation service was recently shortlisted for the Best Elective Care Recovery Initiative at the HSJ Partnership Awards. So well done on that. Tell us a bit about that service and the key impacts to date.
Yeah, so thanks, Helen. Yeah, it was great to be recognised. And actually, I think more than anything, it's really great for our client partners to be recognised, to be honest, almost, more than us as an organisation, because really what those awards are about are the genuine impact being delivered back to patient. It's patient care is at the centre of that. And as I said earlier, the referral triage activity is a growing area. And I think actually, whilst there's some brilliant results from delivering the solution, what it actually really starts to highlight and what we see over time. So I think we often would work with a trust, and it might be looking at clearing their backlog, and we can do that at pace, prioritise the patients appropriately, and clinical and operational teams are really happy with the outcome. And it kind of relieves some of that kind of what's keeping them awake at night pain points. But over time, what we then do is we then potentially move on to delivering the service or the referrals as they come new in through the door. And what that enables is us to provide that kind of maintenance piece. So GPs get very used to having a very quick response back to, is a referral appropriate, or are there alternative pathways for that patient? But I think the kind of aim in all of this actually is to demonstrate the real value of preventative measures, because actually all of that activity is reducing a burden that probably we can reduce if we get on the front foot of it. And that's where I think advice and guidance really, as Anil and Sally said, it's nothing new. It's just become much more kind of key in the NHS, and it's become obviously a focus area, because if you get it right, you're allowing the patients to get the appropriate care most likely quicker at the right time and in the right place. And that starts to really reduce that burden from even happening. So I think that for us is always the aim, to kind of take our client partners on that journey to see the value of that kind of preventative step and the value that it delivers.
Just a final thought, Sally, because they're almost out of time and we've got our keynote speaker standing by. Any challenges, Sally, that you've come across and how you've overcome them as you've been trying to make your system more effective, on this front?
I think it's been made a lot easier by using Consultant Connect. Initially, when we started in 2007, our lovely GPs had to come through the hospital switchboard, where if any of you have tried to get hold of her through hospital switchboards, you can sort of probably average a 30-minute wait. Nobody's fault, just the system. Now they have a response within 30 seconds and they're very appreciative of that. It's just actually the only issue we really have is that some of the GPs, the locum GPs, perhaps aren't aware of the service. They've come from other areas and they're not aware of what a fantastic service we have at the Luton and Dunstable with Consultant Connect working with us. So I have a bit of mantra when I speak with our practice managers and just sort of ask them to educate their locums. When you have a new person coming in and they're going to be referring into the Luton and Dunstable, just always check that they know where the kettle is, they know where the loo is, and actually they know how to refer in using Consultant Connect number and where it is. So, it's just about education, and we're more than happy to support our local GPs because we know how busy they are. And obviously, ultimately, we just need the patient to receive the most appropriate care in the most appropriate place within the 20 frame.
Thank you to all of you. I really didn't know an awful lot about A&G before this panel came up, but I do feel enlightened. So thank you very much to Lucy, to Sally and Anil for joining us. We're now moving on to our keynote from our event partners, Silver Cloud by Amwell, presented by Doug Hiscock. Building digital pathways between mental health services and stages of treatment is key to reducing the admin burden on staff and more efficiently directing patients to the appropriate treatment. Well, over the last decade, NHS talking therapies have used the Silver Cloud by Amwell platform to support almost 700,000 patients, saving an estimated 1.5 million therapist hours. According to the National Institute for Health and Care Excellence, NICE, who evidenced therapists' time taken on a course of treatment, standard care took on average 229.6 minutes of therapist time, while the Silver Cloud Depression Programme only took 92.8. That's a saving of 136.8 minutes. That's 2.3 hours per course of treatment. So in this keynote, Doug presents a vision of what a digitally enabled mental health treatment pathway can look like. Doug, it's over to you.
Hi, everyone. Can you hear me?
We can hear you, Doug.
Yeah, excellent. That's great. Thank you for that. And what an interesting session to follow. It's a very interesting area we've been working with over the last 15 years. My name's Douglas Hiscock. I'm what's called a behavioural health lead within Silver Cloud. My background is I used to run IAP services, now NHS Talking Therapies, over a number of years. Very much got into the idea of how do we automate, how do we allow people to go through their therapy in their own time, how do we get out of the way of people being able to go through the NHS system and through talking therapies, because there's a group of people who are able to do this and a group of people that need support, and how do you build processes to do that. The main thing that was really interesting for me was the advent of digital, and it always seems like it's a very modern thing, but this is almost 15 years ago now, and it is interesting from someone who's worked in mental health services for a number of years. It's fascinating to see that we're quite ahead of the game with our partners who work in physical health. So I have to say, next slide, please. So as everyone knows, that the advent of COVID has really emphasized the need for mental health support. It's really become a very highly needed area, and it's always interesting working in mental health because people always talk about the 1 in 5, 1 in 4. Really, everyone will experience some kind of mental health challenge over their lifetime and will constantly need support from outside of the locals. So it's really good to be able to offer IAP services and primary care services to get that psychoeducation stuff right at the beginning. And as we could see, this problem is only been exacerbated by COVID, and now we are beginning to see quite large waiting lists and IAP services come under strain. And it really is the time to try and make sure that digital is at the heart of what we deliver in a way that supports clinicians and doesn't replace them. And that's a really important thing to do and understand with Silver Cloud. Can I have the next slide, please? So where we've come from, so it's always good to give a little bit of history. So improving access to psychological therapy started some time ago now, and has gone through a rebranding as now NHS Talking Therapies. The whole idea was to provide, right at the beginning, the right level of treatment at the right time for the right people in a way that made it really accessible. And that was a real challenge, bearing in mind the number of people who present with mental health problems. And it has developed the step care model, where at step 2 you get guided self-help, and then at step 3 you're then more likely to get more traditional terms of therapy with someone supporting you through the CBT. Now, what we did at the beginning is we sort of looked at the whole process and looked at really the kind of blockers that get in the way of therapy. One was the fact that it's a very structured approach. You go to see a therapist every week at the same time, at the same way, and that's fine and that's great. But from a person point of view, it's not the most efficient system. And some people are able to map their way through the journey and only need a little bit of guidance, a little bit of nudging. Other people need considerable amount of help. And how you discern that right at the beginning of a treatment is a really tricky thing. And then the other component is empowerment is everything with mental health. If you can encourage someone to do things for themselves and they can work it out for themselves, they're more likely to take on the behaviors that help them in the future. The old adage of the ivory tower and seeing a therapist is not the best way to help people, and getting people rapidly into that support's great. And when I first set up the IAP service in North East Essex, for about a week it worked really well, because we weren't overwhelmed by referrals. And then within about a year, the referrals came in and we started to really struggle to see people at the lower end of the acuity. So we were having waiting lists with people waiting for a long time, and those people who were kind of okay and doing all right, but could do with a little bit of help, would wander off and then come back later on with more high levels of need. So we needed to create a way of accessing support without actually having to be constantly in that kind of this is the therapy session, this is how we see you. So the really nice thing about Silver Cloud is it created what's called this asynchronous way of working, where someone is invited onto the program and they work through it at their own pace. And what you're then able to do is to go in on a weekly basis and see how they're doing, and then nudge them asynchronously without actually having to have a session with them, and see where they are in the process of going through the program. Now, the key thing for that is having the program to be a nice approved, and IAP's very great because it's got a very nice structure and CBT works really well. So we've gone through the whole nice guidance part. So the program is a representation of the protocols for anxiety and depression. So if the person's doing very well from a clinician's point of view, if they're going along the right route in the right way, then you just nudge them. If they're really struggling, you can then have a telephone call with them, support them, and bring them back into the service, or then move them back onto Silver Cloud. And what that allows people to do is to automate a lot of the processes that are needed for that kind of nudging. So you have automatic messages going through, you have ways of checking where people are. If they're getting more risky, those things can be brought into the service. So it allows you to manage the admin and the administration of working in a therapy service, and allow the clinicians to get on with just doing the clinical part of the process. So now, where are we? We're in probably 80% of the talking therapy services in the UK, in England, and also in NHS Wales and NHS Scotland, and we're now in some South Africa, Australia. So everyone's looking wherever the IAP service has gone. Now Canada, there's a lot of interest in bringing over our program to help them support developing that kind of self-guided way of moving through the process, but still at the same time feeling supported by the services. And so with that success, and as we said, those numbers are incredible, and we have to pinch ourselves sometimes. We get loads of really good feedback. We get therapists asking us to do more kind of work, and allowing us to do those things of manualizing and turning those tools that you use in therapy to help people go through and get out of the way of the person empowering themselves through the therapy process. Next slide, please. So this has led us to, we're expanding and moving into other areas where we think we can help services. And one of the ways that we get some of the backlogs under control and back to the way it was before is to try and find a way of delivering therapy that allows the individual to follow the path without having to have a huge amount of contact with the clinician when they don't need it. Definitely when you need it, you definitely need to see a clinician to help you with overcoming things. But how do we automate those administrative processes? And CBT is a classic example. It is full of paperwork, it's full of documents to do, full of tools that need to be done. And what we're trying to do is work with clinicians to enable them to automate those processes and make it easy for those to be transferred into your case management system. So you only spend your time with the patient, doing the clinical stuff, doing the things that really takes a human being to work out how to make people better. And so at the moment, we are beginning to be drawn into secondary care services and people with severe and enduring mental illness, and then into primary care as well, where primary care is still having to manage quite a lot of people who are presenting with mental health problems. Because remember, the step two and three, the target for that is only 25% of the prevalent population. So secondary, a lot of people are still presenting with considerable needs in primary care, and the IAP services don't have the resources to work with them. So we're beginning to build a program with PCNs, with primary care networks, as they're beginning to receive support from secondary care with their ARS workers into the local community. And there again, we're supporting them with a program called Improving Your Mental Health, which is very much a light touch way of helping people who are in that watchful waiting period before they maybe present needing to have more complex support when it goes into IAP service and then into secondary care. And that's really important to understand that's what we're going here. And then obviously with this diagram, we're then still working with step two, but also within IAP services is beginning that process of helping the face-to-face clinicians who during COVID have actually done a lot more work within web-based support, and that's become, in a lot of areas, it's been quite interesting because that's really helped with the efficiencies of services. I worked in a service in London, and then I worked in a service in Bedfordshire. Very different areas where you could walk in Newham, you could walk from one GP practice to another to see patients, but in Bedfordshire we're covering a massive area, and making that traveling across the whole of that county was quite challenging. So what we're doing is working with the clinicians to enable them to use Silver Cloud as a way of using the tools as a way of engaging the patient in the change process that they need to go through. And then also what we're doing is enabling that understanding of how things should work at secondary care. So we're developing programs that are more about empowering the individual with what used to be called the care plan approach, but enabling the person to build a program for themselves that covers things like grounding when they're feeling very anxious, their kind of what medication they're on, and making sure that that's in their program, and then looking at things around support networks and how you develop those kind of things, and helping identify people who are very positive and people who to avoid when you're struggling, and then also around some of the more complex presentations around perinatal work and things like that. So there's a huge amount of work we've gotten involved in, and it's quite an adventure we're on. Now, I'm very conscious of time because there's a great big red thing on the thing. So next slide, please. And I can go on forever, but there is a red flashing thing, which I have to be careful of. So really, the thing to think about is the other part of this is what we call the digital front door. Now, when I set up looked at some data for a service where years ago we thought we were really, really digital because we had a web page and a website. And when we looked at the data, people who do things digitally expect that to carry on throughout their treatment. So what we found was that most of the people that filled in the web form never actually turned up to the service, and those that actually rang into the service would turn up. So having a digital front door that's consistent throughout the whole process is really important. And that's what Silver Cloud's trying to do, is create that kind of, this is your digital companion that can work through the whole process. So the digital front door is important, enabling you to capture the information you need really early on. So when you do your assessments, you're not asking about administrative stuff, you're more asking about the clinical process that you need to go through. And then also the bit that we're looking at is how do we use the kind of chatbot interface that allows you to engage people between the appointments. Like our program's been really good at engaging people between the appointments, but we think it could be even better, that we could create bots that pop up just before a therapy session starts and says, what are the 3 things you're going to bring to the therapy session this time? Clinicians talk about the horrifying moment when a patient comes in and they don't say anything and they just don't have the time to really work through that. So being able to trigger people into the proper way of thinking before they come in is really important. 2 minutes remaining. And then just that whole idea of it being portable, it being in your phone and being accessible and holistic and ongoing past the point. So within therapy, you get 6 to 12 sessions if you're lucky, but actually behavioral change takes a long time. So having the program stay with the person over a year, when we know that after about 12 months, if you're going to try any habit changes, that happens more along that process. So, and also the personalization of it as well, which is quite important. Next slide. And just like one of the things really to be very mindful of in this process is the trust in the platforms. It is a challenging environment to be out there at the moment doing these things. There are quite a few hurdles to overcome. We've gone through the NICE accreditation process, which was a huge endeavor, and we now have to undertake further research as we go on. The idea that the DTAC compliance and making sure that the service is at the level it needs to be, that we're on all the required accreditations, and then just really making sure that people feel that ability to be sure of the program. And just a really something from us is that's a very high level of requirement for us to maintain. So it makes it quite challenging sometimes to move into different sectors and to do new things. And the NHS has to be really careful that what we don't stymie at this time is that flourishing digital approach. Make sure that we know that things are correctly developed, but not to stymie it so much that ideas get lost in the weeds. Just finally, it's great to be here, and it has been quite an adventure, and we're looking forward to the next 10 years working with the NHS. Thank you. That's the 2 minutes.
It's been quite an adventure by the sounds of it, and I'm sure the next will be also quite an adventure. I'm sorry it's against the clock, but you did get a lot of useful information. So thank you for presenting what was a brilliant keynote. And if anybody has got any questions for Douglas, please send them to events@cognitivepublishing.com, and I'm sure they'll get forwarded on. Time now for our final break. Please make full use of the speed networking function, as this is your last opportunity today to do so. I'll see you back here at 3:10.